Today we'll talk about anti-epileptic drugs that routinely we are using now. Before going in detail, first we need to know what are the epileptic syndrome dealing every day in our routine practice, and what are the drugs which are using commonly, and what are the drugs and which situation we should use, doses of the drugs, side effects, and in special population how to use the anti-epileptic drug, and few case scenarios in the PPT. Okay, we'll start the presentation. Next slide. Okay, most of these disorders like epileptic syndromes are defined like classified according to age group and classical electroclinical like easy findings. Most of these neonatal, infantile, and childhood epilepsies will be dealt by pediatrician or pediatric neurologist or adult neurologist. So these diseases you may not able to see in your clinical practice, but you should know the terminologies like Otahara syndrome, West syndrome, Dravet syndrome, Panitopolis syndrome, and Beck's Lennox Gestalt syndrome, Landau-Kleffner syndrome. There are few epileptic syndromes purely depend on clinical and easy findings. Whenever I'm taking the easy classes, I will tell the brief presentation and the classical easy findings of these syndromes. Okay, most of the time you don't see these cases in adult. Like almost these cases will be seen by pediatrician. Like adolescent onset epilepsies, like absence epilepsies, myoclonic epilepsies, progressive myoclonic epilepsies, temporal lobe, frontal lobe epilepsies, Rasmussen syndrome, gelastic seizures with hypothalamic hamartomas, and structural epilepsies and epilepsies secondary to mass lesions or any angiomas or stroke, post-stroke epilepsies. All those things we see in the adult age group. So you should define the epilepsy depending on the clinical features and your easy findings and imaging findings. You should define the epilepsy, what kind of epilepsy patient having first. Okay, next slide. This is the brief about epileptic encephalopathy, like pediatric age group. You should like Otahara syndrome, classically characterized by tonic spasm. Early myoclonic encephalopathy, patient will have partial myoclonic syndrome. In West syndrome, patient will be having infantile spasm and classic easy findings of hips arrhythmias. And in Dravet syndrome, most of the times the seizures will be precipitated by fever, and most of these seizures will be atypical febrile seizure. Can anybody tell what is atypical febrile seizure and typical febrile seizures? How do you say this is atypical? Can everybody try?
Sir, atypical would be some focal seizure.
Atypical febrile seizures. You know,
Uh,
febrile seizure in a pediatric case group after fever, patient used to develop seizures. You might have seen in the pediatric posting and doing uses. What is
sir.
atypical febrile seizure? Because atypical febrile seizures more prone for future epileptic syndromes like Dravet syndrome. What is atypical and what is typical febrile seizure?
Sir, atypical would last for longer, sir.
Okay, longer.
Recurrent
Can
will
define the definition? Longer
uh,
means?
sir, I think 15 minutes, sir. Not
Yes.
sure, sir.
Very good, very good. It is more than 15 minutes. Usually typical seizures will last within 15 minutes. And
Okay.
second criteria?
Sir, multiple episodes will be there, sir, within 24
Yes,
hours.
good, good.
And
In
instead of TCS, it will be focal or partial seizure.
yes, yes. So duration of more than 15 minutes and more than one episode of seizures in a single day or within 24 hours. So that is called atypical febrile seizure. This is classically seen in Dravet syndrome. Okay. So atypical febrile seizures in the pediatric age group will also history also important. And myoclonic status epilepticus, like status epilepticus secondary to myoclonic epilepsies. And last one is Deuce syndrome. This is also called myoclonic astatic, that is myoclonic atonic seizures. And Lennox Gestalt, as all of you know, patient will be having drop attacks, multiple varieties of seizures like focal, generalized, absence, myoclonic epilepsies will be there. And Landau-Kleffner syndrome, as all of you know, patient will have aphasia, auditory agnosia, and continuous epileptiform discharge in the EEG. And ECS is nothing but electrical status epilepticus in slow wave sleep. This is called ECES. This I will tell in the EEG findings. And Rasmussen's encephalitis. This is nothing but autoimmune condition characterized by focal status epilepticus. Okay, these are the few epileptic syndrome that usually we see in the pediatric age group. Just you remember the terminologies. What are the classic triad of that syndrome and what is the classic EEG finding? Okay, these will be helpful for your exams also. Just remember the names. Next slide. So one more thing is idiopathic generalized epilepsy. Young patient or young male, female patient comes to OPD, history of classical seizures, like it may be generalized tonic or myoclonic seizures or absence epilepsies. You did all amazing findings like MRI, you did metabolic parameters, you evaluated everything come normal, and significant history of family history of similar episodes of the seizure. And classically easy finding will be 3 hertz spike wave discharge with normal background. This is called idiopathic generalized epilepsies, where you don't get any particular causes. Other name is genetic generalized epilepsies. Okay, so most of oftenly we see in the clinical practice, drug of choice would be sodium valproate. Okay, here the structural cause will not be there, metabolic causes will not be there, only family history and classical easy finding will help you to diagnose the IGE, idiopathic generalized epilepsies. New terminology is genetic generalized epilepsy. Next slide. Let us come to the classification of anti-epileptic drugs, because depending on the classification we can choose and we can add on the therapy. We should not add same group of drugs. Say for example, patient having generalized seizure, you are given phenytoin. If patient still having the seizure, again you should not give lamotrigine or lacosamide, because all these drugs will belongs to the same group of action. So if you give the same group of drug, it will cause adverse drug reaction, like cardiac sodium channel blockers will causes bradycardias, arrhythmias, cardiac symptoms. So whenever you are combining the drugs, you should be knowing the group of drugs where it exactly belongs. Okay, sodium channel blockers, say for example, phenytoin, carbamazepine, lamotrigine, and lacosamide. And calcium channel blockers like ethosuximide, gabapentin, and pregabalin. And GABAergic drugs like barbiturates, BZDs, vigabatrin. And synaptic vesicle protein 2A modulation drugs like levetiracetam. Can anybody tell one more newer molecule has come of levetiracetam derivative, synaptic vesicle protein 2A modulating drugs?
Brevetiracetam, sir.
Levetiracetam and brevetiracetam, but brevetiracetam is very selective. Okay, it has less side effect as compared to levetiracetam. Carbonic anhydrase inhibition drugs like acetazolamide and other some of the drugs will have multiple pharmaco like GABA, NMDA, sodium channel. So like sodium valproate, felbamate, topiramate will have multiple pharmacological targets. So whenever you are combining, you should be alert. You should not combine same group drugs for seizures. Okay. Next slide. Okay, before you are diagnosed, before you are giving anti-epileptic drugs, you should always rule out epilepsy mimics. Okay, can anybody tell what are the mimics of epilepsy, just briefly?
Pseudo seizures
Okay,
and hypoglycemia.
metabolic causes. Okay,
Then
last time I had told. Migraine with transient ischemic attacks, metabolic causes, sometimes stroke, all those things to be ruled out. So whenever you label patient as epilepsy, again it would be a burden per patient, like in the form of side effects of drug, cost of the drug. So before starting anti-epileptic, you should always make sure that patient is having clinical seizures. Okay, so don't put anti-epileptic drugs to syncopal attacks or other psychogenic non-epileptic events or metabolic causes. Okay, should always root. First you define the type of seizure. So the drug selection would be dependent on the type of seizure. If a patient is having focal seizures, you cannot usually prefer carbamazepine, oxormazepine, labetalol. If patient is having generalized seizure, hello, am I audible?
yes, sir, audible.
Okay, so you should define the seizure type. If patient is having focal seizures, carbamazepine derivatives would be better option. If patient is having generalized seizures, lamotrigine and valproate would be the better option. If patient is having myoclonic epilepsies, again valproate and levetiracetam would be the better option. If patient is having structural epilepsies, the underlying cause should be treated. So whenever you're defining the seizure, so you should be knowing what type of seizure patient is having and what is the cause for the seizures and which epileptic syndrome it come under. Okay, depending on that only you can select the anti-epileptic drug. So you should make sure that patient is having seizures or epilepsy, and the type of epilepsy should be defined before you are starting the anti-epileptic drug. Okay, next. Okay, so basic principle would be, first you diagnose the epilepsy, you choose the patient, and choose the anti-epileptic drug according to the side effect profile. Just you start with the monotherapy, optimize the dose till up to maximum level. Even after that patient is having still persistent seizure, you can add on the drug. Even after that patient is having still seizures, so you need to re-evaluate the patient. Like you can do video EEG, structural causes for imaging like functional scans like PET scan or functional MRI scans should be done. Can anybody tell what is video EEG? What is difference between video EEG and your regular EEG?
Sir,
What is
in
the
video,
advantage?
sir,
Can,
sir, in video EG they use 35 leads. The
okay.
duration is longer.
Okay. Duration longer means?
Uh, Not sure.
Okay. More than 24 hours. Sometime up to 3 days they can put on the put on the monitor. Okay. Then video will be there along with like if patient is having seizure, we can witness also. And in video EEG, we also do tape if you are not sure about the focality of the seizure, if you're not sure about whether patient is having seizures or pseudo seizures, we'll admit the patient, put on the video EEG monitor, we'll start tapering the anti-epileptic drug. Say for example, if patient is having 1000 mg of levetiracetam, we'll taper 250 mg every day or alternate day. After tapering the drugs, if patient started having the seizures, most of the time if true seizures are there, patient will be having reoccurrence of the seizure. So you correlate that seizure attack along with the EEG. So onset ictal EEG would be the best option to find out the focality of lesion. If focal epilepsy is there, you can get the spike and wave discharges according to the lobe. If patient is having frontal lobe epilepsy, the epileptic events will start from the frontal lobe that can be easily identified by your EEG. So for diagnosis, to identify the focality of the seizure, so we can use video EEGs. So after doing video EEG, if you confirm the diagnosis, then you go ahead. If you like after video EEG, there is no evidence of any seizure attacks, then no need of any anti-epileptic drugs. You can do imaging like for structural causes. You can do MRI with proper epilepsy protocol guidelines. Even after that, also if you don't get any particular kind of diagnosis, you can go ahead with the higher end investigations like functional MRI, PET scan, and invasive EEG monitoring, and functional magnetic resonance imaging, or magnetic resonance with MEG, that is MRI guided EEG scanning also be done. After that, you can opt for the multiple varieties of treatment. So you can give according to book they say up to 5 anti-epileptic drug of maximum dose you can try to remit the seizure. Even after that, if patient still having the seizures, you can advise two type of treatment: one surgical or non-surgical. If a patient not ready, if patient is not ready for any surgical intervention, that time you can advise for vagal nerve stimulation, keto diet, or other neurostimulation technique. If patient willing for surgery and we identify the focality of lesion, we can refer the patient for direct surgery. This is the basic approach for uh, anti-epileptic drugs and the epileptic surgeries. Okay, next slide. Next. So first piece like control the seizure with minimal adverse side effect, and epileptic seizures and syndrome should be the diagnosis should be proper, and epileptic syndrome type of epilepsy and etiology should be established, and baseline hematological investigation. Baseline would be CBC, LFT, RFT, and sugars. These are the mandatory investigation before starting or before initiation of the drug. These are the basic investigation to be done for all the patients. Okay. Next, monotherapy would be the best. Always start with a single drug, escalate the therapy till up to maximum dose. Even after that, if you don't get the remission, then you can add on the drugs. Initially, you should start with a low dose as possible, and gradually you should increase the dose. As textbook says, over a period of 2 to 4 weeks, you can increase around 25% of the maintenance dose. Say for example, if patient levetiracetam, we usually give maximum up to, they say up to 4 gram we can give. If a patient is taking 1 gram of levetiracetam, you can increase it by 25% of the dose will be around 250 mg. So 1250 we can increase, or 750 up to 750 we can decrease. So rough, approximately around 25% of the maintenance dose you can escalate, or you can de-escalate the drugs. Slowly we should do, okay, over a period of 2 to 4 weeks. Next. If drug fails, if no, like even after starting anti-epileptic drug, still patient is having similar occurrence of the seizures and adverse reactions are more, that time you can change the drug. You can do alternative monotherapy. If a seizures controlled not to the optimal level, that time you can add on the therapy. If a patient seizure not controlled and adverse reactions are more, that time you can try for alternative monotherapy. And it should be in a slow and step doses. Okay. Next one. Polytherapy could be used whenever monotherapy fails or not able to control the previous seizure attacks. Next slide. Okay, and you should always explain about the epilepsy, epileptic drugs, side effects of the anti-epileptic drugs, and cost of the anti-epileptic drug. So whenever you're writing the case paper, you should always mention drug side effects in a case paper, because it is medical legal aspect also. So if you give carbamazepine patient developed Steven-Johnson syndrome, prior that you are not explained, it would be the legal problem. So whenever you are starting anti-epileptic of any group, you should mention always the side effect, as we explained to the patient or patient attendant regarding the side effects of the drug. If any reactions occurs, kindly stop and come to the emergency. Like that, you should always mention whenever you are starting the anti-epileptic drugs. Okay, be careful regarding this. So if patient developed any complication, you may land up in the legal issues. So whenever you are writing anti-epileptic drug, make sure that your documentation should be proper. Okay. Next, so depending on the age, gender, special age group, economic status, all those things, all these factors also influence the selection of anti-epileptic drug. And you should see for the comorbid condition, physical and mental status, employment, education, and emotional circumstances, and the patient compliance to the drugs, and factors that are related to the epilepsy and epileptic syndromes, severity and chronicity of the epilepsy, etiology of the epilepsy, and factors which are related to the drugs, drug interaction and pharmacokinetic properties. All those things all those things to be kept in the mind before you are starting anti-epileptic drugs. So first one is you should define the seizure, and you should see the patient profile, and you need to see whether patient belongs to the special population like women, pregnancy, lactating mother, elderly age group. These are the special population. In that setting, what should be done? Okay, these are the basic principles of treatment of seizures. So we'll go to the selection, anti-epileptic drug selection. So whether we should give anti-epileptic or not, which anti-epileptic is better, when to start the treatment, which anti-epileptic we should give, dose of the anti-epileptic drugs, and when we should add on the drug, and when we should stop the drug, and what all the side effect and cost of the anti-epileptic drug. All those things to be kept in the mind whenever you're starting the anti-epileptic drugs. Okay. So as I told earlier, to rule out psychogenic epileptic events, syncope, metabolic parameters, movement disorders, sleep disorders, transient ischemic attacks, migraine, transient global amnesias, all those things to be ruled out. So when to start treatment? What is unprovoked seizure and what is provoked seizure? Can anybody tell? Can anybody? It is in the name only. Unprovoked. Provoked. Provoked means some cause should be there. Say for example, hypoglycemia, hyponatremia, hypocalcemia, encephalitis, structural mass lesion. All those things are come under provoked seizure. Unprovoked means there is no evidence of any focality or any cause for seizures. So when to start anti-epileptic drug? Should we start anti-epileptic drug in an unprovoked case in a first episode, or should we wait? Okay, next slide. First, we need to classify the risk stratification. Okay, whenever patient comes to you after having a seizure, you need to stratify the risk according to the risk stratification. First, you need to see prognosticate. In that, three headings are there. So if patient is having only one episode of seizure prior to the presentation, it will carry points of 0. 2 to 3 episodes will carry 1. 4 or more seizures will carry 2 points. If any neurological deficit, learning disability, developmental delay is there, you give 1 point. Abnormal EEG is 1 point. In that, low risk would come under 0, medium risk would come under 1, and high risk will come under 2 to 4. In medium risk and high risk patients, you should always give antiepileptic. In low risk, again, you need to explain the patient regarding the future risk of reoccurrence of seizure depending on the cause. Okay, next slide. So, okay, when to start antiepileptic drugs? If patient is having two unprovoked seizures, which are occurring 24 hours apart, this is the definition of epilepsy. Okay, in this setting also we need to give. If a patient is having abnormal MRI, abnormal EEG finding, abnormal neurological examination, remote brain injury or any structural lesions, most of the events that are occurring in nocturnal events, and if patient presented to the emergency with status epileptic, because in this setting, we need to start antiepileptic. Next slide. Next slide. Okay. So if a patient is having only one seizure, you have not got any cause for the seizure, even after detailed examination and clinical findings and investigation, you can label it as first unprovoked seizure. Okay, you should explain the patient regarding if we don't start anti-epileptic, there will be chances of getting the seizures around 20 to 45% of the patients over a period of 2 years. Then you need to explain the side effect of anti-epileptic drugs also, and you should tell the patient and patient attender regarding that. If they are ready, if they are willing for anti-epileptic, that time you can give. Otherwise, you tell, and chances of getting a seizure also should be explained. And if patient is having two unprovoked seizure, you should always start with the anti-epileptic. So chances of 57% of the people will be having the recurrence of seizures in the first year, and 73% of the people will be having seizures in the over a period of 4 years. Okay, immediate treatment of the first unprovoked seizure. In the first 2 years, it will not change the long-term remission. So even after giving the anti-epileptic in a first unprovoked seizure, they will not change the duration of remission, unless associated along with it will be having the side effects secondary to the anti-epileptic drugs. Any doubts in this slide? First unprovoked, you need to explain regarding a reoccurrence and side effect of the anti-epileptic drug. If the patient is willing to take anti-epileptic, give. If not willing, you can tell the risk of reoccurrence, and accordingly you should plan. Okay, if two unprovoked seizures are there, you need to start anti-epileptic.
Understood, sir.
Okay, next slide. So which anti-epileptic drugs? Anti-epileptic drugs broadly classified as first generation, second generation, and third generation. The drugs which are come before 1993, that is called classical anti-seizure medicine. First drug was the bromide, and the last one was felbamate. The drugs which are appeared in the market after 1993 to 2008 are second generation, from felbamate to lacosamide. The drugs which are come to the market after 2008 until now, these are called third generation anti-epileptic drugs. These drugs will come like lacosamide, gabapentin, clobazam, perampanil, eslicarbazepine, and recent one is brivaratrexton, which had come to the market in 2016 and approved for focal monotherapy. Okay, next. So choice of drug, this is the table from our classical Harrison textbook. Generalized seizures, first line would be valproic acid or lamotrigine. We need to see again the side effect profile that I will be telling in the next slide. For focal, lamotrigine, carbamazepine derivative, levetiracetam, phenytoin. And for typical absence seizure, age of the child more than 2 years, it would be valproic acid. If age is less than 2 years, ethosuximide would be the better option. If patient is having atypical absence, myoclonic, atonic, that time you can prefer valproic acid or lamotrigine. As you see in the Lennox-Gastaut syndrome, patient will be having multiple kinds of seizures. In that setting, valproic acid and lamotrigine would be the better option. And other alternative drug, as I mentioned in the slide. See the patient profile and side effects. Okay, if patient who wish to have avoid cosmetic side effect, like cinema actors or those who are having particularly those who wish to particularly avoid a cosmetic side effect, you should not give phenobarbital, phenytoin, or valproate, because these will cause us sunlight, it will induces the rashes on the body, and valproate usually it causes the hair fall. Okay, in that setting you should avoid these drugs. If patient is having already prominent anxiety, behavioral problems, psychiatric illness, better you avoid levetiracetam because it will aggravate the psychiatric behavior. So in that setting you can use clobazam, carbamazepine, valproate, and phenobarbital. Okay, if patient is having prominent depression, better if patient is having prominent depression, better you use carbamazepine or valproate. Better you avoid levetiracetam and phenobarbital and vigabatrin. If patient is having renal stone, you should not give astazolamide or topiramate or zonisamide because it will precipitate formation of the renal stone. Next. So if a patient is having migraine, meanwhile having seizures also, better choice would be valproate and topiramate. If patient wants to lose the weight or if patient not wants to gain the weight, in that setting again topiramate and zonisamide would be the better option. Gabapentin, pregabalin, valproate, again it will increase the body weight in a particular setting of obesity, obstructive sleep apnea, and polycystic ovarian diseases. Okay, in that setting better you avoid these drugs. If patient is having history of chronic or acute hyponatremia, in that setting you should avoid carbamazepine or oxcarbazepine derivatives. If a patient is having drug allergies, risk of allergy, in that setting you should not give carbamazepine, phenytoin, astazolamide, or lamotrigine because these drugs will have higher chances of Stevens-Johnson syndrome. In that setting, better use alternatives like clobazam, lacosamide, levetiracetam, topiramate. If a patient is having heart risk, like cardiac illnesses, in that setting, better you avoid carbamazepine, lamotrigine, oxcarbazepine, and lacosamide also because these are the sodium channel blockers will have chances of reoccurrence or occurrence of the arrhythmias, and it will sometimes prolongs the QT interval that will leads to the arrhythmias. Okay, better in cardiac patient you avoid these drugs. So if patient elderly having osteoporosis and recurrent pathological fracture, in that setting better you avoid phenobarbital and phenytoin because indirectly it will cause osteoporosis. You can use gabapentin, pregabalin, or levetiracetam. If patient is having enzyme interactions like CYP mediated mechanism, in that setting you better use clobazam, lacosamide, levetiracetam because valproate and phenytoin, phenobarbital, these will interact with the metabolism of the drug. So better you avoid that kind of drugs. Okay. One minute. Sister. Okay. Okay. If patient is having risk of hepatic enzyme mediated interaction, that time you use these drugs. Okay. Avoid valproate, phenytoin, and phenobarbital. Next. So particular drugs which are particular to the age group, elderly better you use lamotrigine or levetiracetam. In a female with a reproductive age group, pregnancy, that time lamotrigine would be the better option. If a patient is having liver failure, use levetiracetam. or lamotrigine or gabapentin. If a renal failure is there, use lamotrigine or valproic acid. If patient is having concomitant depression, again you can use valproic acid, oxcarbazepine or lamotrigine derivatives. Any doubts till now? If any doubts, kindly ask me now regarding selection of anti-epileptic drugs.
No, sir.
Okay, next slide. So one should kept in the mind. So after diagnosis, hello, tell me. Hello.
Yes, sir.
Anybody wants to ask anything?
No, sir.
No. Okay, continue.
We will continue, sir.
So whenever you are giving the anti-epileptic drugs, you should be kept in the mind that what all the drugs should not be given in particular kind of epilepsies. Like in case of myoclonic epilepsies, absence epilepsies, atypical absence, some of the drugs which are strictly contraindicated. In absence epilepsy, if you give carbamazepine, phenytoin, or oxcarbazepine or vigatripine, it will precipitate the absence seizure episodes. Okay, in a case of myoclonic seizure, again, if you give carbamazepine and oxcarbazepine phenytoin, again it will precipitate the myoclonic seizures. In atypical absence or atonic seizures, again you should avoid carbamazepine, oxcarbazepine, phenytoin derivatives. So after diagnosis, should alert enough that you should not give these are the following drugs in that particular setting of the drug. Okay, setting of epilepsy: absence, myoclonic, atonic, and atypical absence. Okay, in this setting, you should not randomly give like carbamazepine, phenytoin. Okay, you define the epilepsy, plan accordingly. Next. So what is the difference between newer and older drugs? As says, the efficacy is like same as older and newer drug efficacy would be same. Only factor is cost and side effect. Side effect profile would be better in newer drugs, and cost is more in newer drugs compared to the older. And drug interaction also less in newer drugs as compared to older drug. Depending on the patient economical status, you can adjust the drug and the dosage. Okay. Next slide. Next slide. Okay. Let us come to the doses of the drug. From what dose we should start, how to escalate the dose, and how to de-escalate the dose, up to what dose we can go ahead. The most commonly clobazam, lacosamide, levetiracetam, phenytoin, and valproate. Carbamazepine we can use maximum up to 2,400 mg. Interval dose will be 2 to 3 times in a day. You start with a low dose, like from 200 mg per day, and gradually escalate over a period of 2 weeks. And whenever you're tapering, also same 2 to 4 weeks, over a period of 2 to 4 weeks, you should reduce. As I told earlier, around 25% of the maintenance dose you need to taper or you need to escalate. Say for an example, if a patient is taking a drug carbamazepine 1000 mg, the 25% of the drug would be around 250 mg. So that 250 mg, so grossly it will come around 200 mg. You need to escalate or de-escalate over a period of 2 weeks. For same for the clobazam, you start with the 10, go up to 30 mg, and lacosamide you start with 50 mg and go up to 400 mg. Levetiracetam you start with 250 to 500 mg, then you can go up to 4 grams. Phenytoin you start with 200 mg, you can go ahead till up to 450 mg. And valproate you start with 500 mg and escalate up to 3000 mg. Okay, the tapering should be over a period of 2 to 4 weeks and approximate around 25% of your maintenance dose. Okay, any doubt in escalation or de-escalation of anti-epileptic drugs? Most oftenly we have difficulty in these tapering up or escalation of the dose. Okay, we face commonly, especially in PG days. Any doubt regarding escalation or de-escalation?
Sir, levetiracetam can be given till 4000 mg, sir.
Maximum up to 4 grams
Per day, sir.
per day. So they say up to 60 milligram per kg we can go levetiracetam. Only problem would be higher doses will cause abnormal behavior. Sometimes acute severe psychosis, behavioral problem would be the most side of. Even after 2 grams, patient will be most irritable and behavioral issues will develop. If patient tolerating well, then you can go up to 4 grams.
And sir, phenytoin generally we give 100 mg 102.
Your voice is not clear.
Hello, sir.
Tell me.
Sir, phenytoin generally we give 100 mg 102, sir. That comes to be 300 mg per day, sir.
Okay.
So initially we should initiate only 200 mg, sir.
Initially they say 3 to adequate dose would be like 3 to 5 mg per kg day say. Ideally phenytoin initially you should start with TDS dose. Like you calculate 3 mg per day. Say for example, if the patient weight is around 60 mg, take 3 mg. So 3 into 6 around, it will come around 200 mg. Okay. You start with 100 mg BD. Then gradually you increase up to most of the patient by 300 mg, the seizure frequency will come down. First, you always start with TDS dose. Then you can give extended release 300 mg in the night. Whenever patient like after 2 or 3 weeks of therapy, you can directly shift for 300 mg HSR. Extended release preparations also available. Better you start with 200 mg, 100 mg BD. Then you make it 100 ml TDS. Then after 2 to 3 weeks, you can give 300 mg HS extended release tablets.
Okay.
Okay. So this is the same chart as I told earlier. Classify the anti-epileptic drug according to the mode of action. Then you decide what all the combination can be done for the patient. Okay. Next slide. Okay. This is a principle of anti-epileptic combination. So use anti-epileptic drugs with different mechanism of action. Say for an example, sodium channel blockers like lacosamide and lamotrigine, we can combine with the non-sodium channel blockers like valproate or levetiracetam. Or use anti-epileptic drug combinations with better efficacy, which are seen in the RCTs, like carbamazepine with levetiracetam in focal epilepsies. And use the anti-epileptic drugs with favorable pharmacokinetic interactions, like levetiracetam, lamotrigine, lacosamide will have least pharmacokinetic interaction. So, okay, in that setting also you can be used. Avoid the combinations like same sodium channel blockers, like carbamazepine, phenytoin will have same mechanism of action. Carbamazepine, lamotrigine again same mechanism of action. Better you avoid these kind of combination because it will cause the pharmacological or pharmacokinetic interactions. Again, one more this previous the articles they have commented like carbamazepine, valproate or vigabatrin combination for focal epilepsies, or vigabatrin with thiagabine for the focal epilepsies, valproate with ethosuximide for absence seizures, phenobarbital and phenytoin for generalized tonic seizure, lamotrigine with topiramate for various kind of seizures because multiple mode of action of topiramate. These are the few combinations. Okay. So you need to see always carbamazepine for Stevens-Johnson and hyponatremia, valproate for metabolic syndrome and hair loss, phenytoin for gum hypertrophy and marrow depression, clobazam for behavioral changes and irritability, topiramate for language disturbances and renal calculi. Any other side effects other than these I mentioned? Topiramate. Can anybody tell? Other important side effect of topiramate? Okay, it will cause angle closure glaucoma also. So whenever starting topiramate, you need to take an ophthalmologist opinion to check for the intraocular pressure. If patient is having pre-existing glaucoma, better you avoid topiramate. Okay, before you are starting, you should see whether patient is having any renal calculi history or any glaucoma history or language disturbances, cognitive problems. Better you avoid topiramate. Levetiracetam, as all of you know, mood disturbances. Lamotrigine, again, deadly complications, Stevens-Johnson syndrome and rashes. Okay. These should be kept in the mind whenever you are starting anti-epileptic drugs. Next. So again, this is the side effect chart. So most of the anti-epileptic drugs will causes skin reactions, liver toxicity, pancreatitis, bone marrow suppression, and lupus-like symptoms. So before starting the drugs, you see this chart. If patient is having pre-existing illnesses, better avoid according to the drugs. Okay, next slide. So how long should we give the anti-epileptic drugs? All these depends on the probability of the relapse, depending on, as I told earlier, one risk calculator score I told. If patient is having high risk or medium risk, there will be higher chances of relapse. If patient is having severe adverse reaction, that time also you need to stop and change the anti-epileptic drug. And patient compliance and legal implication like driving, job issues. In that setting also, very should be careful regarding the continuation of the anti-epileptic drug or duration of the anti-epileptic drugs. Next slide. So when to stop the anti-epileptic drug? This is the most common scenario whenever we are doing the medicine posting. So chances of reoccurrence of all types of epilepsy after 2 years of seizure-free period would be around 20 to 30%. Most of the reoccurrence will occur in the first year of seizures. So if a patient is a seizure-free for more than 2 years after stopping the anti-epileptic drugs, there will be less chances of reoccurrence of seizures. Okay, so minimum mandatory period would be 2 years, and after that you see the patient profile and the diagnostic condition, then only you decide if a normal EEG is there, no structural epilepsy, and complete remission of the seizure after 2 years, then in that setting we can stop the anti-epileptics. If a patient is having epileptic syndrome, structural epilepsy is there, family history significant family history of seizures are there, in that setting you are not able to stop the anti-epileptic drugs. Next slide. So you see the risk factor for the reoccurrence, as I told earlier. Next slide. So patient, those who are having abnormal EEG at the presentation and at the like completion of anti-epileptic drug for a period of 2 years, even though patient is having abnormal EEG, that time also you cannot able to stop anti-epileptic. If patient is having persistent neurodeficit and structural lesion, even after 2 years, that setting also you cannot able to stop. And occurrence of multiple episodes of seizures and multiple varieties of seizures or status epilepticus and long duration of therapy and the seizure control, in that setting also you cannot able to stop the anti-epileptic. If you stop, there will be high chances of reoccurrence of seizures. And in case of epileptic syndrome and in case of multiple episodes and multiple types of seizures, and complex partial seizure, that is focal impaired aware seizures, in that setting also you cannot able to stop, because in that focal epilepsy there will be causes like medial temporal sclerosis, focal heterotopia, or focal cortical dysplasias will be there in setting of complex partial seizure. And the type of seizure, like if patient is having epileptic syndrome, Lennox-Gastaut, Dravet, West syndrome, in that setting also you cannot able to stop the anti-epileptic drug. And whenever you are starting anti-epileptic drug, you should always inform, as all of you know, most of us will be working in the government sector. Patient will be poor, they cannot able to afford the drugs for at least for a period of 2 years. So because because of that, you should always explain the cost of the drug. For example, levetiracetam 500 milligram for 10 tablets, it will be around 106 rupees. For a month, it will cost around daily for a month it will cost around 600 to 700 rupees. So you need to explain the cost of anti-epileptic drugs whenever you are prescribing, because again, if cost is more, again they will stop the drugs, and because of poor compliance, again they will land up in the emergency. So you see the patient profile and economical status and affordability. According to that, you need to plan. For example, Phenytoin for 100 tablets, it will cost around 133. So 100 tablets mean 3. So in a 130 rupees for a complete 1 month, patient can able to take tablets. So economical status and cost of the anti-epileptic drugs is also important whenever you are deciding the anti-epileptic drugs. Okay, next slide. So come to the special situations like elderly, females, and breastfeeding, and some of the risk factor if the patient is in that setting, what all the anti-epileptic we can try. In a case of elderly patients, well, most of the patient will be having associated neurological conditions like dementia, stroke, and cerebrovascular diseases, and various pharmacokinetic interactions due to the less clearance due to renal and hepatic impairment and decrease in the protein level. All those things will affect the pharmacokinetic of antiepileptic drugs in elderly. Okay, next. So half-life of the drug is more in elderly as compared to young, and protein binding capacity is lesser in elderly patients, and the renal and hepatic clearance is also less in elderly. So even at a low doses also patient will be having chances of adverse drug reaction in an elderly age group. So whenever you're giving the dose and you are monitoring, you should always give better on a lower side of the lower maintenance dose rather than going up to the maximum. As I mentioned, like levetrestam we can give up to 4 gram in a young patient. So in an elderly you should not go to the higher level of the drugs. Okay, next. Because more elderly patient will have more sensitive neurological side effect of the drugs due to the increased drug concentration in the serum. Okay, lower drug doses are sufficient to control the seizure. As minimum dose of you should be knowing what is the minimum dose in that patient will have complete remission of the seizure. So according to that you need to give the dose of the drug. Next. So better you avoid membrane stabilizing drugs, that is like sodium channel blocker, especially phenytoin, carbamazepine, lamotrigine. You avoid in the elderly because that will lead to the arrhythmia and hypotension, sudden cardiac arrest. So you should better you avoid phenytoin and carbamazepine, but lamotrigine can be given if ECG and cardiac condition is good. And patient is having already osteoporotic. Again, if you give phenytoin carbamazepine, that will lead to the pathological fracture. So better you avoid phenytoin and carbamazepine in an osteopenic patient, especially in elderly. And carbamazepine have some anticholinergic side effect that will causes the urinary retention in the elderly. So avoid carbamazepine in elderly. Next. So better drugs would be levetrestam because it has good tolerability, good pharmacokinetics, less drug interaction. Titration we can do early as compared to other drugs, and parenteral preparation also available. And next better would be gabapentin. After that, lamotrigine. These are the 3 drugs in elderly would be the better choice for management of treatment. If patient is having focal or generalized seizure, these drugs will have broad spectrum of action. Okay, it covers focal and generalized seizures also. Levetrestam and lamotrigine can be used in elderly. So epilepsy in women, because there will be high chances of infertility in a patient those who are using the anti-epileptic drugs. Okay, the one study showing that fertility rate is 47 in a patient who using the anti-epileptic drug as compared to the normal fertility rate 62%. Okay, 62 per 1,000 women. So next one to the pregnancy, particularly in the last trimester, more chances of pharmacokinetic interaction because of increase in the body fluid volume and hormonal imbalance. The serum levels of phenytoin and phenobarbital will fall up to 40%, and in a lamotrigine up to 60%, and in a setting of carbamazepine, carbamazepine is very less as compared to other drugs. So phenytoin, phenobarbital, or lamotrigine will have very low level in the low drug concentration in the pregnancy. There will be high chances of reoccurrence of seizures. Okay, as I told earlier. Next slide. Carbamazepine, oxcarbazepine, levetrestam have less pharmacokinetic interaction in a pregnancy. Okay, lamotrigine, like in lamotrigine, it will reduce up to 60% of the maintenance dose. So in a pregnancy, we need to escalate the dose of lamotrigine. Okay, so phenytoin, phenobarbital, lamotrigine will have severe pharmacokinetic interaction. Carbamazepine, oxcarbazepine, levetrestam will have less pharmacokinetic interaction. Okay. Next. Teratogenic, as I told, all of the drugs will have teratogenic side effects. So least would be lamotrigine, that is 2%, levetrestam 2.4%, phenytoin 2.9%, and highest would be valproic acid 9.3%. So whenever you are prescribing anti-epileptic drug in a pregnancy, again you need to document in a case paper regarding these data. Okay, so whenever giving the levetrestam, you should mention there will be chances of abnormal or developmental delay in the baby around 2.4%. So you should always mention in the case paper. This slide you better you take screenshot and keep it in the phone. So whenever prescribing anti-epileptic drug in the pregnancy, you should always mention and you should always explain to the patient, attender or patient regarding the side effect of anti-epileptic drug. So least would be lamotrigine and levetiracetam 2 to 2.4%. So you document it and you explain them risk of malformation in the baby, those who are taking anti-epileptic drugs in the pregnancy. Okay, this is very important. Any doubt in this until now?
So if the patient is already on valproate, sir, and she presents 3 months after pregnancy, what to do?
In that setting, most of the time organ development will occur before 10 weeks of pregnancy. So patient already taking anti-epileptic, you should never change. You should tell them to continue the same anti-epileptic drug and you should explain around 9.3% risk of baby malformation. So if patient come before conception, you can try taper and at least waiting period of 3 months and give a good amount of folic acid at around 5 mg for a period of 3 months. Then you add, you replace the anti-epileptic drugs. So if patient comes already conceived, patient come for the consultation, that time you cannot able to do anything. Okay, most of the organs will be developed over a period of 8 to 10 weeks. Okay, that time you should tell the patient and patient attendant to continue the same drug after explaining the risk. Okay.
Okay.
Okay. So spina bifida in normal population, it will be around 2.2 to 0.5%. In valproate, up to 2%. In carbamazepine, 0.5 to 1%. Okay, these are the malformation. Okay, spinal cord or any developmental malformation after anti-epileptic use. So next one is breastfeeding. What all the drugs can be given in breastfeeding and what all the drugs should be avoided? Carbamazepine, ethosuximide, phenytoin, valproate will not excrete in the breast milk. So we can give the drugs, these 4 drugs. Some of the drugs should be given with a caution, like benefit versus risk ratio. Clobazam, clonazepam, gabapentin. 1 minute. So in breastfeeding case, better use with a caution because these drugs will excrete into the breast milk. It will cause the side effect in the baby like sedation, irritability. So with caution, we can use clobazam, clonazepam, gabapentin, lamotrigine, levetiracetam, oxcarbazepine, topiramate, and vigabatrin. And felbamate and zonisamide is strictly contraindicated. You should not give felbamate and zonisamide in a breastfeeding woman. It will cause us because it will cause 100% milk excretion and fetal drowsiness and fetal seizure chances will also be there. So better you avoid felbamate and zonisamide. And for phenobarbital, there are no consensus till now. Okay, better safely we can use carbamazepine, ethosuximide, phenytoin, and valproate in a breastfeeding woman. In polycystic ovarian syndrome, valproate it do causes PCOS, so it will causes obesity. So better you avoid valproate in young female patients. Okay, there are like one study showing that 30 to 40% of patients, those who are taking valproate, had polycystic ovaries and hyperandrogenism, as compared to 5 to 15% those who are taking carbamazepine and lamotrigine. So better you avoid in a young female patient, especially obese and PCOD, and those who are having issues with the conception. And in 23% of the cases with lamotrigine, but it is highest for the valproic acid. Next. One more thing is catamenial epilepsy. The seizures which do occur during the follicular phase of the menstrual cycle are called catamenial epilepsy due to the increase in the estrogen. Estrogen itself is an epileptogenic agent. So due to the premenstrual tension and the water retention, that will be contributing factor for the catamenial epilepsy. The treatment would be we can give acetazolamide or clobazam. The 5 or 7 days prior to the menstrual cycle, we should start acetazolamide 250 mg BD, and after completion of cycle again we can stop the drug. And clobazam also have some benefit, and we need to rule out other epilepsy, because most of the time in a hyperestrogenic status, normal epilepsies like myoclonic epilepsies, absence epilepsy will also precipitate during the menstrual cycle. So you should not label it as catamenial epilepsy only. So you rule out other associated epileptic syndrome along with the catamenial epilepsy, because in catamenial epilepsy, regular antiepileptics are not needed. Only as an like before the starting of the menstruation, like 5 to 7 days before the menstruation, we can give the acetazolamide or clobazam, you can stop, but unlike other epileptic syndrome. Okay. So seizures and the labor. This is the most commonly we dealing with the OBC references, cross references during the PG time. So labor is itself a stress condition. So chances of increase in the seizure episodes during the delivery are postpartum. And sometimes if patient is having eclampsia or pre-eclampsia, that also eclampsia is nothing but your pre-eclampsia with seizure. So patient will have chances of occurrence of the seizures. So when in a pre-eclamptic patient, there will be chances of 1 to 4% of the pre-eclamptic patient will go for eclampsia. Okay, treatment would be magnesium sulfate, loading dose around 3 to 4 grams, then followed by 1 to 2 grams hourly. What are the things to be monitored whenever you're giving the magnesium? Can anybody tell? What are the side effects of magnesium sulfate?
So deep tendon reflexes.
Okay, good. Then
ECG abnormalities.
good. Then magnesium levels should also be monitored. Okay, if magnesium levels are too high, you should not give the magnesium infusion. So that will cause cerebral again drowsiness. It will cause. Okay, whenever you're giving magnesium, be careful. What all other condition we can use magnesium? Any use of magnesium other than this eclampsia? Where else you can?
COPD, non-reversible COPD.
Okay, then ventricular tachycardia you use magnesium.
And non-responding hypokalemia.
Hypokalemia. So whenever patient have hypokalemia, do magnesium level, give magnesium supplementation. And other two indications are in refractory cramps also we give magnesium, and in setting up refractory migraine, magnesium and riboflavin combination can be given, and it is safer in pregnancy also. The proven benefit would be migraine, cramps, COPD, ventricular tachycardias, and postpartum or during labor if patient is having seizure or eclampsia. In that setting, magnesium can be used. Okay, next slide. So mechanism would be it inhibits the NMDA receptor, decreases the cerebral hyperexcitability, and it acts as a pre-radical scavenger also. So oral clobazam can also be helpful in the additional prophylaxis of seizure during the labor. And if patient is having seizures, even after giving the magnesium sulfate, also if patient having continuously convulsing, you can use other drugs like benzodiazepine, phenytoin, levetiracetam also can be used in case of severe seizure even after magnesium sulfate. Okay. Most of the time you will get the reference from the OBC like postpartum seizures. So tell them to give. So first you confirm it is eclampsia or not eclampsia. Okay. If patient is having eclampsia, that setting you give magnesium sulfate. If even after that patient is having recurrent symptom, that that time you can give antiepileptic. So again, meanwhile you rule out cortical vein thrombosis or any intracerebral hemorrhages also, because most of the time patient will be having associated other etiological agents. So don't like put into only eclampsia table only. Okay. Next slide. So again, in pregnancy, valproate is contraindicated. The risk rate of fetal malformation would be around 9.4%. Okay. IG is nothing but idiopathic generalized epilepsy. As I told earlier, there is no cause with significant family history, classical EEG findings, MRI, and metabolic parameters would be normal. IG in pregnancy, lamotrigine, levetiracetam, and carbamazepine would be the better option. Don't give valproate. Valproate is drug of choice in other scenario. In all the patients, valproate is the drug of choice in IgE, except in PCOD and pregnancy. Okay, next. So as I told earlier, teratogenicity prevention, as most of the major malformation are established within first trimester, many of within the first 8 weeks. So optimization of therapy should be carried out before conception. So referral of a woman for a review of drug therapy when she is 10 weeks, it is too late to make changes. So you should tell and you should explain and tell them to continue the same anti-epileptic drugs. Okay, and you should make sure that always give folic acid in a higher dose, as they say 5 milligram daily supplementation of folic acid, at least like prior to the conception, like 3 months prior to the conception, you start folic acid, and throughout the pregnancy you give, because it will decreases the risk of fetal malformations. Okay, especially spina bifida, occulta, meningocele, myelocele, all these notochordal defect will come due to the folic acid deficiency due to long-term usage of anti-epileptic drugs. Okay, make sure that folate should be added and risk should be explained, and that should be documented in the case paper. Okay, in a pregnant woman. Okay, don't forget, because if any legal actions which occur, you will be held responsible. Okay, next slide. So we'll see the some case scenarios. So say one example, a 24-year-old female patient planning for marriage, or she conceived, or she is in first, second, or third trimester labor. If she is having idiopathic generalized epilepsy or migraine, another 2-3 conditions are there. Next. Okay, go back to previous slide. Okay. Can anybody tell what all the drugs can be used in this setting? One by one you tell. Option A. If a woman, now in case of epilepsy, planning for marriage, what will you advise? One by one, kindly tell me.
Levetiracetam or lamotrigine.
Okay, already patient is having alternate drug. Already she is taking phenytoin or valproate. She come to the OPD, sir, I am planning for a marriage. I want to change my anti-epileptic drugs. What can be done? In that setting, what will you do?
So slowly taper off those drugs and start Levipil or lamotrigine.
Lamotrigine, levetiracetam, and one more, carbamazepine also. Oxcarbazepine also be given. So previous drug you should taper gradually. Tell them to like at least they should use contraception, or tell them to like delay the marriage for at least period. But tapering up the actual drug, it will take time, 2 to 3 months it will take. So 100 or 200 mg for every 2 weeks means it will take around at least 2 to 3 months. Okay, till that time, better you delay the marriage or use contraception properly. And meanwhile, you should tell always folic acid supplementation. So if patient comes before marriage or before conception, you taper the drugs, switch it over to the safest drug, add the folic acid, and continue. Next, UPT is positive. If a patient come in first, second, third trimester, what will you do?
Continue same medication.
Yes, continue. Advise the continue same medication. Explain the risk. Document in the paper. Okay, what all the I told from 2 to 2.4% to 9.3% risk rate for individual drugs. You should advise. You should tell, and you should document in the paper, and tell them to continue the same drugs. If a seizure comes in the labor,
Rule out eclampsia first.
yes, good. Eclampsia and eclampsia mimics. Okay, if eclampsia is there, give magnesium sulfate, wait and watch. Again, severe risk of reoccurrence of seizure is there, give other anti-epileptic drugs. Okay. Idiopathic generalized epilepsy in a young female.
Levetiracetam, sir.
Okay, levetiracetam or lamotrigine. Okay, if a patient, 24-year-old female patient, epilepsy, having severe migraine.
Topiramate.
Okay, topiramate. Topiramate can be tried. Again, it is also teratogenic. So before conception or before marriage, again you should advise. Okay. Next slide. Okay. 25-year-old male. If patient is having a hypersensitivity action like skin reaction, allergic history, autoimmune disorder, if he is having presented with history of generalized seizures. What all the drugs should be avoided?
Carbamazepine,
Phenytoin should be avoided.
Phenytoin, phenobarbital, carbamazepine, and one more, deadliest Steven Johnson, lamotrigine. Okay, lamotrigine should also be avoided. These are the 4 drugs you should never give if patient is having already history of say hypersensitive reaction or any drug allergies or any rashes. Okay, if patient is having thin build, don't want to lose the weight, so other than which all
Valproate,
the causes weight loss, antiepileptic drugs which causes the weight loss,
pyramid, and valproate.
valproate, topiramate and zonisamide better you avoid. It will causes weight loss. Okay, in thin patient is there again. If you give topiramate and zonisamide, again there will be weight loss. Okay, you avoid topiramate and zonisamide in thin build persons. Okay, if a obese patient come, what other drugs should be avoided?
Valproate.
Then other drugs, pregabalin, gabapentin derivatives also avoid. If patient is having severe psychosis,
Levetiracetam should be avoided.
okay, can we use brivaracetam in the setting of levetiracetam? Anybody use brivaracetam? Nizam? Okay, brivaracetam can also be used. It has also a risk of psychosis, but for levetiracetam it is around 9 to 11%. For brivaracetam it is 2 to 3%. So even that also better you avoid levetiracetam or brivaracetam. Both have psychosis risk factor, but levetiracetam is more compared to the brivaracetam. Okay, in the setting don't use brivaracetam or levetiracetam. Other drugs can be used. That is helpful would be valproate and carbamazepine, because valproate and carbamazepine act as mood stabilizing agents also. Okay, you can see in psychiatrists like bipolar disorders, all those things they use this carbamazepine and valproate also for mood stabilization. Okay, so in that setting you can use. Okay. Next, okay, CLD, most of the people you see alcoholic liver disease, cirrhosis of liver presented with a seizure, for maybe n number of causes, hyponatremia or hypoglycemia. In that setting, which drug you want to give?
Sir, clobazam, levetiracetam, lacosamide.
Clobazam you can give CLD patients. Will you give? What will cause? What will it cause? Again, it is hepatic mediated mechanism. Na? It will precipitate hepatic encephalopathy. Better don't give benzodiazepine in CLD. You can use levetiracetam. CKD, again you should avoid levetiracetam because levetiracetam will be excreted in the kidneys. In that setting, you can use valproate. If cardiac arrhythmias are there, better you avoid sodium channel blockers. Hyponatremia, again avoids carbamazepine. TB or HIV, you need to see for that drug interaction. Most of the time, isoniazid, rifampicin, and NRI, NNRTI will have enzyme related, like enzyme induction agents are there, no? That will have drug interaction. Phenytoin, phenobarbital, and valproate will have drug interaction with these antiretroviral therapy or ATT. So in that setting, you avoid those drugs. And hypoxic ischemic encephalopathy, the choice would be levetiracetam because most of the time will be associated with myoclonic drugs. Levetiracetam, valproate, and clobazam would be better in hypoxic ischemic encephalopathy. Okay, next slide. You better these are the drugs. You just see the drugs. Okay, carbamazepine, oxcarbazepine, phenytoin, lamotrigine, all these drugs details in this chart. So what are the drugs, spectrum of activity, dose of the drug, side effects, again the same story you see once you get the free time. Okay, last slide. Okay, previous. Okay, so what are the tests to be done in a routine? So before starting and once in 3 to 6 months in all patients those who are anti-epileptic, because we'll have potential bone marrow suppression, hepatitis, and renal dysfunctions. Okay, better you get baseline CBC, LFT, RFT before starting also, and if possible better once in 6 months. And calcium, alkaline phosphate, and vitamin D level every year, because the drugs which will causes osteoporosis, osteopenia. So if having lower level of these drugs, so you can add on calcium supplementation. Routinely anti-epileptic drug level cannot be not recommended if a patient is having complaint issues or anti-epileptic drug toxicity, or in a special situation like liver injuries, renal injury, pregnancy. In that setting, you can order anti-epileptic drug level. So phenytoin, phenobarbital, levetiracetam, all the drugs level can be done. So initially, you should follow up the patient with 2 to 4 weeks. Then once seizure settled, you can tell them to review once in 3 months or 6 months, and you should give seizure diary. Okay, I will share the seizure diary photo. You can give it to patient attender. Whenever seizure occur, that day and time and number of episode should be mentioned and should be taken to next OPD visit. Okay, thank you. Any doubts?
Sir, when a patient presents in casualty, he is a known case of seizure disorder, suppose say phenytoin, sir, and he is not taken not compliant to medications. So now when he
Okay.
presents with new episode of seizure, we have to load with the same. We have to load, no sir, with the same group of antiepileptic, same eptoin only we have to give.
You are sure that poor compliance is there? Or if you want to confirm it, you can send for anti-epileptic drug level. Okay.
Okay, sir.
You can get the drug level if it is too less. Ideally, normal drug level for phenytoin would be 10 to 20. If it is less than 10, definitely there is poor compliance is there. That time you can, if patient not having any side effect or any adverse reactions related to the phenytoin and well-controlled seizure with the phenytoin, prior well-controlled seizure will continue. Say for example, patient had having severe side effects of phenytoin, and even after phenytoin also he was having the seizure. In that setting, you need to advise regarding the alternative option. Okay. Because in most of our government hospital, we'll get only phenytoin.
Yes.
Levetiracetam is available.
Yes, sir, available.
Available in our hospital. Okay,
Yeah, yes, sir.
Sir, phenytoin, how to give a dose? Can it be given fast, sir?
Your voice is not clear.
Sir, phenytoin when we are giving, sir, what is the rate, sir? How to give?
Samir, your voice is not clear.
Hello, sir.
Your voice is not clear.
Am I audible, sir? Hello, sir.
Tell me.
Sir, when we give phenytoin, sir, what is the rate at which we give, sir?
Ideally, it can be given like first you need to calculate the dose.
Yes, sir.
And you dissolve in 100 ml NS. So this is up to 30 minutes. Within 30 minutes, you should give the phenytoin. For fast phenytoin, only 10 minutes is enough. So whenever you're using phenytoin, you can give within 30 minutes. If you don't give within 30 minutes, it will lead to the crystallization of that bottle. Again, it will crystallize, and drug will have not have any good effect. Okay, you give within 30 minutes.
Okay, sir.
They say I think 1 to 1.5 milligram per kg. Exact, I'm not remembering. Within 30 minutes, you should give. Okay.
Okay, sir.
Sir. So patient, next scenario, sir. Patient known case of seizure disorder.
Okay.
He's compliant to the medications, but still
Okay.
he's an episode of breakthrough seizures today. After evaluation and repeat imaging, and we found nothing new abnormalities are not there, but he's still trying convulsions, sir. So
like what was the cause for seizure? Better you tell this is as epilepsy. Okay.
Okay, sir.
Don't use the term seizure. So seizure is only for only one episode. Unprovoked seizure is the patient having only one seizure.
Okay.
Okay. If patient is having recurrent seizure, your terminology should be epilepsy. In epilepsy, again, you need to define whether patient is having focal epilepsy or generalized epilepsy. Again, in focal, impaired or aware. Again, in generalized, you need to define myoclonic, atonic, or absence. Okay. What kind of seizure patient is having? You are telling generalized seizure.
Yes, sir. Generalized seizures.
Generalized tonic, clonic, or myoclonic seizure?
Tonic-clonic seizure, sir.
Tonic-clonic seizure. Cause was nothing. You didn't get any cause.
No, sir.
Like it is idiopathic generalized epilepsy.
Okay, sir.
Okay, in idiopathic generalized, which drug patient was having? Was
Sir,
on?
he was on tablet phenytoin, sir.
How much he was taking?
100 mg in the morning and 102, sir. 100 in the morning, 200 at night, sir.
200 at night. What was the weight of the patient?
Sir, around 60 kg male patient, sir.
I think you are giving adequate dose. So you are giving adequate dose of anti-epileptic. Even after that, patient is throwing the seizure means first one you should inquire whether patient taking. Compliance is very important. Okay, if compliance is normal, again you need to address the risk factor for reoccurrence of seizure. Say for example, if patient is having fever, if patient is having dehydration, if patient is having other metabolic problems, or if patient taking alcohol or any drug addiction, these things also be seen. Everything is normal, drug level is normal, adequate dose you are giving, still patient is having seizures, then you need to add on the drug. If idiopathic generalized epilepsy is there, if a patient is male, you can choose valproate would be the better option. If female patient is there, like all those risk factors, like you see the risk factors and you add on the drug.
Okay, sir.
You need to address why recurrence is happening, whether compliance issue or systemic causes, or whether any uh, uh, any problem in our diagnosis of epilepsy. Okay.
Sir, in case of alcohol withdrawal seizure, sir, what to do, sir? Do we load anti-epileptics or
No,
just
in alcohol withdrawal seizure, you don't give any anti-epileptic drugs.
just
Only give
benzodiazepine?
short course of benzodiazepine,
Yes, sir.
taper over 7 to 10 days.
Yes, sir.
You refer the patient for psychiatry to
Yeah.
de-addiction. Don't give any anti-epileptic.
Okay, sir.
Because most of the patient, alcoholic patient, one more thing is alcoholic patient already immunocompromised. Chances of having cortical vein thrombosis, tuberculosis, or any like metabolic, like thiamine deficiency, all those things will be associated. Things will also be there. Don't treat as like alcohol withdrawal only. So rule out the other causes also. Okay, if other causes are not there, then you can give just lorazepam or the benzodiazepine, which are the benzodiazepine available, and slowly you taper over 7 to 10 days and refer the patient once he stabilizes to the psychiatry department for de-addiction.
Hi, sir. I had one more doubt, sir. Now, for ADS and AWS cases, psychiatric people have shifted from lorazepam to diazepam. Any particular reason? Diazepam, sir. Initially they were using lorazepam, sir. But now these people have started using diazepam, sir. Any specific reason, sir, for shifting?
Diazepam, like quick action, duration is very less, and quick action will be there. For acute setting, diazepam would be better than your lorazepam. And lorazepam time of action is also more. It will act till up to 12 hours, and action of activity will start after 15 to 30 minutes. But diazepam, it will start within 5 minutes, and the duration of action is very less, 1 to 2 hours it will. So for quick action, short duration action, you give diazepam, but for the maintenance, lorazepam would be the better. BDR, TDS dose.
Yes, sir. Thank you, sir. Thank you so much.
Okay.
Sir, one more doubt, sir. Sir, 20-year-old male, sir, a new onset seizure disorder, epilepsy, and we've confirmed, sir.
You should tell diagnosis. I've taken already one class. You define whether patient having epilepsy or seizure.
Epilepsy, sir.
Okay, epilepsy. Generalized or focal?
Generalized epilepsy, sir. Generalized tonic history
Generalized
of
clonic epilepsy. Young male patient. Okay.
20-year-old male patient, weight around kgs. History of alcohol abuse is there, sir. Last drink 2 days ago.
Okay.
MRI, brain imaging is normal. So neuroparenchymal abnormalities are not there, sir.
Okay.
Routine electrolytes, everything has come back normal. Started on injection phenytoin, sir, because that was available in our casualty. Loading dose, and after loading dose, seizures didn't occur for 6. First dose was given at 7 a.m. in the morning, sir. The repeat dosing, TID, it was supposed to go, sir. So afternoon dose is gone. Before the evening dose is gone, patient had one more episode of again generalized tonic-clonic seizures.
Okay.
So in this setting, sir, do we have to give the dose of eptoin before the time it was supposed to be given, or should we consider giving another anti-epileptic drug?
two concepts are there. When a patient is having seizures, even after giving the loading dose of one drug, two scenarios: you can repeat the half dose of phenytoin, or you can completely replace that. You can completely take away from, like, phenytoin you continue, you can add on the drug, one more drug, which is like in liver injury, CLD you told, na? Alcohol withdrawal or CLD?
Alcohol withdrawal, sir.
Alcohol withdrawal. So you can add valproate or levetiracetam to the add-on drug. So you are giving already full dose of phenytoin. Any other, like even alcohol also precipitate the seizures. Patient already is having idiopathic generalized epilepsy. Alcohol is precipitating the seizures. After giving phenytoin, still persistently patient is having seizures. You can take two options. One, you can give half loading dose of phenytoin, or you can switch it to other anti-epileptic drug, valproate or levetiracetam, which do cover generalized tonic-clonic epilepsies. And meanwhile, you see for the cause, imaging is normal, metabolic causes you should see.
Sir, now with the combination of these two drugs, then seizures did not recur. So for maintenance, the patient has to take both of these drugs, no, sir?
Yeah. So whatever the drugs which are given during the acute phase, you need to give all the drugs while discharging. Okay. After that OPD subsequent visits, you can gradually taper and make a suitable drug for according to the patient clinical profile and economic status. After that, you can taper. So whenever you're discharging, give same drugs which had given in the hospitalization. Okay. Don't give single drug and send them.
Sir, what is the cost of drug levels outside?
Phenytoin, I think it is 2,000. Carbamazepine, it costs more. Carbamazepine, oxcarbazepine costs around 4,000 to 5,000. Levetiracetam, not all the laboratories they are doing. Levetiracetam is, I think, costlier compared to other. Phenytoin, phenobarbital are like around 2,000. Other drugs levels are too costly.
So one more doubt I had, sir. In case of IC, sir, we start Levipil.
In case of
IC intracranial bleed.
Intracranial hemorrhage, okay.
Give prophylactically anti-epileptic drugs, sir. So till what duration we have to continue, sir? Any guidelines of particular 3 months?
Why you want to give prophylactic anti-epileptic?
In case of large ICA bleeds, some neurosurgeons advise, sir.
They advise, but there is no guidelines. Only prophylactic anti-epileptics are indicated only in subarachnoid hemorrhage. Subarachnoid hemorrhage. There are post-stroke seizure, one entity is there. Okay. Like after seizure, embolic stroke, most of the time it do affect the cortex, cerebral cortex, that will causes the seizure. Classified as early post-stroke seizure and late post-stroke seizure. Early post-stroke seizures means less than 2 weeks of stroke. More than 2 weeks of the stroke, late onset post-stroke seizure. So you should first classify whether patient is having early post-stroke seizure or late post-stroke seizure. In early post-stroke seizures, you can give 2 to 3 weeks to 2 to 3 months, then you can taper and you should stop. In late onset seizure, patient will have high chances of reoccurrence of seizures and converting into epilepsy. In that setting, you need to give at least 2 years. So you classify post-stroke seizure as early and late. In late, you should give for a long period. In early, you can give from 2 to 3 weeks to 2 to 3 months and you can stop.
Okay, sir.
I'll talk on provoked seizure. One presentation will be there. What all the duration of anti-epileptic in provoked seizure, unprovoked seizure, and post-stroke epilepsies. Okay. Yes, and prophylactically, you don't give any anti-epileptic unless patient is having subarachnoid hemorrhage. Okay. In that setting, you need to give whether patient is having seizures or not. Okay. I told in the prior class also. Colloidal vesicle stage of neurocysticercosis and your subarachnoid hemorrhage. Only these are the two indicated conditions without any evidence of seizure. In that setting, you give without any evidence of seizure. Rest other condition, you should not give. Okay. Neurosurgeon, most of the time, even subcortical bleed, basal ganglia bleed, and brainstem bleed also they will prescribe. Okay, don't give.
Okay, sir. Thank you, sir.
Because unnecessary anti-epileptic you give, again patient will be sedated, your sensorium will come down. Because of drug side effect, the outcome would be poor. Okay, don't give anti-epileptic. If patient is drowsy, you do EEG, you monitor EEG at least for 24 hours. If EEG showing definitely epileptic form discharges, that time you can give. Okay, without confirming the diagnosis of seizures, don't give any anti-epileptic drugs prophylactically.
Yes, sir. Sir. Okay.
Okay.
Sir, to stop any anti-seizure medication should be 5 years seizure-free period, sir.
2 years recent guidelines. For pediatric, they say sometimes you can postpone up to 3. Most of guidelines, they say 2 years. Previous guidelines were 2 to 5 years they used to tell. Now it is 2 years. You see, and reoccurrence, high risk reoccurrence, I told you, that risk calculator and factors for reoccurrence of seizures like epileptic syndrome, structural epilepsies, multiple episodes of seizures, epileptic encephalopathies. Okay, family history of seizure. In that setting, you should not stop and you should not taper the drug and should not stop. If everything is okay, no risk factor of reoccurrence, and your risk calculator score is also less, that time you can take a chance after completion of 2 years of anti-epileptic course. Okay.
Thank you, sir.
Thank you. Over.
Thank you, sir. Thank you.